Hello, everybody. It's a pleasure for me to be here today and to have the chance to collaborate with Medscape in this quite interesting series about melanoma and other tumors, but mostly melanoma and skin cancers. And I thought that for this first video, I would introduce myself and let you know a little bit about my passion around melanoma investigation and also why this is important to continue on speaking about in the next couple of years. And you can see already in my slide my background and also my contacts. So feel free to contact me if after this talk you have any questions or any aspects that you would like to learn a little bit more in detail. So these are my disclosures, and I will be sharing this slide pretty much in all my presentations. And before I start to talk a little bit about clinical data and clinical science, I would like to share with you this concept that it's called the golden circle. And basically what it says is that if you want to make a difference, but on the other side, if you want to keep yourself motivated on the long run, your most important question is your why. Why are you doing whatever you want to do, clinical investigation, other type of research, clinical activity, and so on. And once you answered your question why correctly, then you can answer the questions on how and what in an easier way, but also in a way that keep yourself motivated in the long run. Because whatever you are in terms of your career, this is something that you probably will like to do for a long time. And if you have any doubts of what are you doing in the meantime, and if you are doing it correctly, then you just need to go back to your why question. And I find this quite, I would say, supportive from a clinical perspective, but also from an investigator perspective, because sometimes we'll lose a little bit sight of what we are doing. And if we remember our why, then it's easier to go back. And to start, why are we discussing about skin cancers, but mostly about melanoma? And the reason why is because despite some awareness that is available and is known about the skin cancers and also the risk factors associated with melanoma and skin melanoma, the reason or the reality is that indeed the number of new cases that will be diagnosed with melanoma, of melanoma, will continue to increase. And this is work that we published a couple of years ago that shows exactly this, that the number of new cases will continue to rise. It is true that the majority of them will be diagnosed in an early setting and mostly treated with surgery, but some of them will at some time require some systemic therapy or some other therapy besides the initial surgical therapy. The how question, and I think for those that never read the book that is on the right side of the screen, you should try to buy it and read it because it actually puts in perspective the way that clinical investigation or investigation in cancer has been done in the last century and how things evolved in the way that we see it now. And if you read it before, you remember that there was mention to the backbone of chemotherapy that was given for pretty much all solid tumors. And then it was adding some therapies, whatever those therapies were, to this backbone of chemotherapy. And my impression nowadays is that we have this PD-1 backbone therapy that we are using pretty much in all the settings and in all tumor types almost. And then we are adding to this PD-1 backbone therapy in the hope that we are producing better outcomes for our patients. In some cases, this is true. In other cases, we are adding toxicity similar to the backbone of chemotherapy that we had before. And I think it's also important that we think a little bit outside of the box and what we can offer to our patients besides this chemotherapy or besides this PD-1 backbone that we have now and the way that we combine it. The question on what, and I think the question on what it's clear about, it's clear for melanoma, and the what, it's the number of therapies that we have been producing or that we have been, that our patients have become available in the last, I would say, 20 years. And these go by immunotherapy, immune checkpoint-based therapy, but also target therapy. And for those that are less knowledgeable about these two type of therapies. I'm just going to show you a couple of slides next, and then during my next talks, we will look into more detail about these two therapies and what we can offer to these patients indeed in different settings. Starting with immune checkpoint inhibitors, the investigations and the outcomes from identifying, but also being able to use immune checkpoints as a therapy for solid tumors, and in particular for melanoma, led to two of the investigators to receive the Nobel Prize. They are identified here, and probably you know about it. And this is one of the first papers that was published about the CTLA-4, one immune checkpoint inhibitor that we use pretty much every day in our clinics for patients with stage 4 melanoma. The paper was in 2003, so more than 20 years ago. And it was a phase 1 study with first in human, with the primary endpoint that was safety. And when we look into safety, nowadays we are pretty much knowledgeable about the type of immune adverse events that the patients can have once they receive this therapy. But at the time this was published, these new adverse events were completely different from the adverse events that we were used to when we treated the patients with chemotherapy. And I can imagine that this was not so easy to convince people to invest in such a trial that had such different adverse events, and in some cases severe adverse events. And you can stop the presentation here and think about whether you would fund a phase 2, phase 3 trial using this molecule. And I would say that with this data, I'm quite convinced that the majority of us would say that they would not fund these kind of trials, which would all be wrong, as you know by now, because these are the outcomes of melanoma-specific survival using PD-1 and CTLA-4 in monotherapy or in combination. And we have now 10 years melanoma-specific survival data showing the difference, the fantastic difference that we have between what we had before in terms of survival outcomes and what we have now, because these two therapies are available, not just for melanoma, but for other solid tumors as well. For the target therapy, these are also impressive images that were published almost 2 decades ago as well. For the first time that a BRAF inhibitor was used in patients that had a BRAF mutated tumor. And you can see that the effect is quite fast. The patients respond very fast, but we also see a recurrence that comes also fast after starting therapy, especially monotherapy. Later on, we were able to identify other parts of the MAP kinase pathway that could be inhibited, and now we use mostly the target therapy as combined therapy. And we also have data from almost 7 years survival from patients treated with target therapy and patients who have melanoma. So although in the beginning, we have a very brief overview or a very brief pick of what exactly these type of therapies can provide to our patients. The reality is that if we keep ourselves true to our why, it might be that in the near future we can actually provide such outcomes for our patients if we, as I said, continue to ask the right questions and keep yourself on the right path. And with that, I finished my presentation for today, and we will see each other in the next couple of days. And I'm looking forward to continue having this interaction with you in the future. Thank you very much.